Good morning. Yeah, great. So it's a pleasure to be here and talk to all of you. It's a wonderful group. I love being outside there. There was so much interaction and noise and talk and connecting. I'm going to talk about antiretroviral therapy. We should have plenty of time for questions. So if I don't cover something that you want covered, I'm happy to stop at the end and answer questions. It's totally fine. Also, we're going to have a session in the afternoon where if your questions haven't been answered all day, you can bring them in the afternoon. We're going to have experts, myself, David Wall, Susanna Nagy, and anybody else I can drag up on stage to come and be experts. So again, thank you for being here. So I'm going to talk about antiretroviral therapy. I don't think I'll cover anything Dr. Cohen did, but if I do, I'll try to make it clearer. I only saw the end of his talk, to be fair. I know he talks incredibly fast. I think everyone here knows the goals of HIV therapy, but I think it's important to keep these goals in mind. This is kind of an inverted pyramid. Obviously, what we're trying to do is restore and maintain health of people that have HIV. That's our goal. And we do that, in part anyway, through suppression of HIV replication. And that's what our therapies do. But in addition, we need to minimize both the short-term and long-term adverse effects of our therapy. And our therapies now are pretty potent. They work pretty well. So we really need to focus on preventing toxicity, tolerability issues. And then the third thing, of course, is that we have to get therapy that everyone can access. And that's, I think, really our biggest challenge. We talk about curing HIV or making the perfect vaccine, but really getting people tested into care and keeping them in care is critical. And then if we can do this, if we can find and treat most people with HIV, we'll have the other advantage of preventing transmission to those who don't have HIV. Because if we suppress viral load in people who have HIV, then they're very unlikely to transmit to someone that is uninfected. So you probably know that worldwide we actually have these huge goals. These are goals set up by the UNAIDS and the World Health Organization. Their goal that's set for us is by the year 2020 that 90% of people that have HIV will know that they're infected. Of that 90%, 90% will be on treatment. And then of that 90%, 90% of those will be suppressed. So if you do the math there, it's about 73% of all people with HIV will be suppressed on therapy. And there's a model, and these are models. I don't know if Dr. Cohen talks about models. He talks about people in their pajamas sitting around making these models. And he may have talked about that. This is like the guy who robbed a bank and looked at the gun, and when it didn't work. I guess I don't have a pointer, but on the bottom, on your right, is what would happen if we reached that goal in terms of number of new HIV infections, and then also the number of HIV-related deaths. The number of HIV-infected people will go up because people will survive, but the number of new infections will go down, and the number of deaths related to HIV will go down substantially. And I think this is a remarkable number. In the world, there are almost 16 million people.
The top of the circle is a laser pointer.
The top of the circle. Oh, yeah, there you go. That, like the little light thing on the top? Beautiful. Okay. That's why I'm a doctor. So anyway, there are 16 million people in the world that are on antiretroviral therapy. That's remarkable. How many people in the world aren't infected? Anybody know what the number is?
37 million.
Yeah, something like 35, 36 million. So it's still, we're a little less than half. But maybe we'll get there. So If you think about that 90-90-90, it actually turns out, and if you had asked me this 15 or 20 years ago, the easiest 90 to get to is actually the one all the way to your right, getting people suppressed on therapy. Getting people diagnosed, getting people into care, that's not so easy, but getting people suppressed. So can antiretroviral therapy hold up its end? And the answer to that is an unequivocal yes. This is a study called the START study. The START study was designed to see whether, if we start people with CD4s greater than 500, is there a clinical advantage? This is one of the most important studies that has been done, I think, almost ever in HIV, because it clearly shows, so people who had CD4s above 500 were randomized either in red to start therapy right away, or wait till their CD4 fell to 350 or less. And this is the number of these are primary events, so that's an AIDS event, death, or a serious non-AIDS event like cancer, heart attack, stroke. And what you can see is, I think it's pretty obvious that it was substantially better, more than 50% better to get on therapy earlier. And the other thing, this was a study where people who went on therapy, there was a whole menu, and some of our coordinators here that did this are in the audience. There was a whole menu of therapy. You could pick whatever you thought the best therapy was for that patient, and if they had a problem with it, you could switch. And this shows you this is months here, within a few months, almost everybody was on therapy, and almost everybody was suppressed. And then so 60 months, 5 years, almost 95% of the patients on the study stayed suppressed for 5 years. So it works. If we get people therapy, it works. And now we want to get people therapy no matter what their CD4 cell count is. So that is pretty much one of the big messages. No matter what the CD4 cell count, we should start therapy. And this just shows, again, this is the difference in terms of events. And these serious adverse events or death were reduced by almost 60%. And the thing is, almost 70% of those events occurred before the CD4 count fell below 500. So this idea, well, maybe I should wait around, they're 700, 800, I got plenty of time. Well, you have some time, that's true. But it's changed my mind about how quickly we should be getting people on therapy. And another really important point is these were not just some, candidal esophagitis, which you treat with 10 days of fluconazole. I mean, I don't want candidal esophagitis, but you could argue, well, that's not so bad. There were almost three times, not quite, as many cancers in people that deferred therapy. And Kaposi sarcoma, lymphoma, anal cancer, and multiple other types of cancers occurred more commonly in people deferred. So I think unequivocally, beginning therapy is the right thing to do regardless of CD4 cell count. And this is just another study that was done. This was done mostly in Africa and showed really literally the same thing, that starting above 500 was important. This particular study, which doesn't really apply to us, also showed that if you're in an area of high tuberculosis incidence, it made sense to put everybody on isoniazid. That also, so getting on antiretroviral therapy and getting isoniazid, that's the bottom line here, was the thing that protected people the best. Fortunately, we don't have to do that here. TB incidence obviously is very low, but in other areas, that's important. Now, I'm sure Mike talked about this. This is 052. If START is one of the most important studies that have been done in the last decade, this may be the most important study in the last decade. And I want to point out a couple of things in this. I'm sure he's already talked about it. The way I think about this study is, first of all, antiretroviral therapy is not magic, right? It's not magic. The viral load needs to be suppressed. So people on therapy did transmit, but they almost always, in fact, I think if one looks carefully at that, they always had a detectable viral load. So if you suppress the viral load, the likelihood of transmission. You can never say anything is zero, but it's very, very close to zero. The other thing that's important, and I guess we all know this at some level, is in this study, there were a lot of transmissions that were not linked, right? So these are the linked transmissions. So in the early treated group, 16 were not linked, and in the later treated group, 16 were not linked. So people do have sex with other people that they don't see as their primary partner, and that may influence how you use something like PrEP, which we can talk about later. But obviously, not all primary relationships are monogamous. So those are my two takeaways from this. Oh, my builds didn't build. Oh well, that's a bummer. So how do we do in the U.S.? You know, like the one big deal with this 90-90-90 thing is when they show U.S. data, it doesn't look that good. In fact, places like Botswana and other places do actually much better than we do. And our problem, right, is this. Diagnosed, maybe 86% of people in the U.S. have been diagnosed. I don't know how they get this number, to be honest. How do they know how many people are infected if they're not diagnosed? So that's an estimate, right? And you can fudge these numbers by changing that very first denominator. So I'm always a little skeptical about other countries that say, oh, 93% of our population is diagnosed. Well, how do you know that? But what I will say is that once we get people engaged in care, we do a pretty good job. And this comes from a research group that the UNC is involved in. And this looks at how we do in, it's called NA Accord, which is about almost 100,000 patients throughout North America. And basically, if we can retain people in care, about 84% are prescribed HAART, and you might say, well, someone is retained in care and isn't prescribed ART, so that's an issue. Why is that happening? So we need to know about this 16% gap. But then if you are prescribed therapy, over 90% are suppressed. And that's the numbers we see in our clinic. In fact, I'm always like shocked and surprised and anxious when I see one of my patients who isn't suppressed, and I'm sure many of you feel the same way. And this is an example of other countries that can do better. This is the cascade from Australia. This was given to me courtesy of David Cooper. They also have a drop-off in terms of this being diagnosed and receiving treatment, but it's not as dramatic. And in their hands, if people are receiving treatment, 92% of their population is suppressed. So once we get people on therapy, we really can get them suppressed. So why is ART so successful? Why does it work? Well, it's potent. There is, if you choose any of the regimens recommended by the Department of Health and Human Services, you have chosen a potent regimen. It's relatively simple. We have multiple single tablet regimens now. I think if you have a treatment-naive patient who doesn't have resistance, you can almost certainly get that person on a single tablet regimen. There may be a couple of exceptions. One would be if they actually have frank renal failure. At least today, it may be hard to get them on a single tablet. But other than that, I think you can get them on a single tablet. I'm not saying a single tablet's always the best, but you could do it. The pharmacokinetics are incredibly favorable. I think if you take another thing away from here, another important thing, is our drugs are remarkably forgiving. I don't particularly like that word because it's used a lot, and companies use it to say their regimen's more forgiving than another one, and it makes me think of Catholic grammar school and confession. And but what it means is that these drugs they're not immune to human nature, but they certainly are helpful with human nature. And human nature is forgetting your medicine, not getting your prescription, forgetting to get your refills in time, faxing the clinic and having it be a day where no one's in clinic, and the prescriptions don't get refilled till tomorrow. Human nature. There's no way, and David, I hope, would agree with this, there's no way that 90 2% of the patients in our clinic are taking 95% of their pills. It's just not possible. They're humans. And all of us have had this experience where someone comes in and says, I ran out of my medicines 3 weeks ago and I didn't get them refilled. And we get their viral load and it's suppressed. And that's because our drugs have excellent pharmacokinetics. People's viral loads are really suppressed. We're doing a study in the ACTG where we're using this single copy assay to do the most sensitive tests possible. And about 35% of people have less than 0.4 copies per ml. Even with the most sensitive assay we got, we can't detect virus in their blood. And the average is 1 copy. So our therapies really work. And for the most part, they're really well tolerated. And one reason for that is I've decided that we are now in the integrase era of antiretroviral therapy. So this is just our clinic here at UNC. The slides got a little messed up, but the basic message is this is the proportion of new patients started on an integrase inhibitor, and purple is the integrase inhibitor. And here's 2012, and it's about 30%. Here's 2013, and it's about 70%. And here's 2014, and it's about 85%. So new patients are being treated with integrase inhibitors. And why is that? Because they're very well tolerated. They're very potent. And the proof that they're very well tolerated, again, this again comes out from our clinic, from Sonia Napravnik and Thibaut Davy, who work with our database. And this is what's called persistence. Persistence means if you start someone on a drug, a combination therapy, how long do they stay on that exact therapy, right? How long before something happens? In this particular analysis, if you had a break of 2 weeks, you were considered interrupting, which is a little bit rigorous, but that's how they decided to do it. And for example, so if you started on a boosted PI, by 2 years, 40% were no longer on that regimen. By 3 years, about 60% were no longer on that first regimen. On the other hand, if you're started on an integrase inhibitor, and a lot of this here is people not coming back to clinic or maybe not tolerating one of the drugs in the regimen, but up to 6 years now, we haven't even reached the 50% mark. People stay on the therapy that they're started on because it's a good therapy. So our integrase therapies are persistent. People don't change. They don't have to change. They don't have a problem. But so, why do we need new therapies? We're done. We have them all. Well, if you think about it, someone walks in to your clinic. They're 25 years old. They get started on therapy. How long will that person need to be treated? 6 decades, 60 years. What if there's a baby that gets infected, which happens rarely, but maybe once or twice a year in North Carolina? That baby needs to be treated for 80 years, unless Dr. Margolis really gets to work and cures HIV. So we really need therapies that are incredibly safe, maximally tolerated, and include a wide range of choices, and not just choices in terms of which pill, but maybe not pills altogether. Maybe not everybody's meant to take a pill. Maybe we need other alternatives. And we have these other problems like renal and cardiovascular, liver and bone toxicity. There's probably toxicities we don't yet know about. What about the safety of ART in pregnancy? We want, there's no reason why a woman who's HIV infected who wants to have a family shouldn't. She should. But we need to know about safety. And we don't have as much data as we like. Therapeutic options for kids are really limited. Then you have to deal with adolescents. Who here has an adolescent in their home? Who has tried to get them to do anything? Can you imagine having an adolescent who had to take a pill every single day and they had to take it and you were afraid that if they didn't take it, something really bad would happen? Maybe birth control pills are in that. At least at my house. But it's stressful. And if you had an alternative, a patch, a shot, something that was implantable, maybe that would be better. And people get tired, tired of taking therapy. Life is chaotic. People get surgery. People have to travel. So we need to really work about this. And there's this treatment gap that I mentioned, right? This gap. So in our group, this big North American group, 84% in people in care are on therapy. That means 16% aren't. Why not? Why are people who are in care not on therapy? Well, maybe some of them are transitioning and they're off just for a short period of time, but some of them have mental illness, right? And we can't figure out the right therapy for them. Some may have drug-drug interactions that are difficult. Some may have substance use issues, and we're not sure that it's best to start their therapy. So there's this treatment gap, which is really important. And I think also there are probably people out there who know they're positive, and if there was other forms of therapy, long-acting therapy perhaps, maybe they would be more likely to come into care. And then finally, we need new drugs because HIV resistance is always with us. I have no idea what happened to my slides. And I'm sorry about that. So I'm going to talk about some newly available therapies and therapies that are coming available. One is this drug tenofovir alafenamide fumarate, or TAF. We all need to know about TAF because it's now available in multiple forms. And it's very similar to TDF. We used to always say tenofovir, but now we have to be very careful. We have to say tenofovir disoproxil fumarate, or say TDF, which is a little easier. This TAF has smaller milligram doses. It can be used in renal dysfunction, so down to a creatinine clearance of 30. We actually have a study that we're doing right now of giving a single tablet therapy to people on dialysis. So one pill once a day in people on dialysis. So if you have anybody on dialysis that's HIV positive, give us a call. Because it's simple therapy, and if those of you who have a patient on dialysis know that, well, they're taking their TDF once a week, and they're taking 30 milligrams of 3-TC, and then they're on, an integrase inhibitor, which they're supposed to take every day, and it's very confusing. We have an alternative to efavirenz that's being developed called doravirine, and we have a new integrase inhibitor that's being developed that David Wall has been working on. That doesn't require boosting, so it's similar to dolutegravir. And the phase 3 studies are underway, and people are now actually testing 2-drug therapy. So instead of 3-drug therapy, testing 2-drug therapy. Why would you do that? Well, it might be less expensive, it might be less toxic, and in settings where therapy is very resource limited, it may be more feasible. So this is the TAF drug. In this setting, this is a head-to-head comparison of elvitegravir, which people probably know as an integrase inhibitor, cobicistat, which is a booster, TAF, and FTC. Compared this, everything's the same, except instead of TAF, it's TDF. So this, for level setting, this is Stribild, and I'm only going to say the trade names one time, and this is Genvoya. And David Wall did the study. In fact, he just published 96-week follow-up, just came out in the last couple of days. And what it shows is that this TAF-containing regimen was as good as, numerically slightly better, as the TDF-containing regimen. And at 96 weeks, the data held up. It's very strong. So why do this? It's just as good. Well, oh my goodness. I guess I should have come up here and gone through my slides. It has 2 really big advantages. One is bone density. So TDF reduces bone density somewhere between 2 and 3%. And we know everybody who gets it, it's about 2 to 3% reduction in bone density. And then it tends to stabilize. Again, we know it's stable for a few years, and we also know it's been studied mostly in people who are between the ages of 30 and 50, and mostly men, who don't really have that many issues with bone density. But what does TDF do to a woman who's going through menopause? Does it make it worse? Or as someone gets older and their bone density declines? Well, with TAF, this was actually a switch study from TDF-containing regimens to TAF-containing regimens, and you can see that bone density improved here by about 1.5% in hip and in spine, somewhat greater in other studies, and there's improvements in renal tubular function. We don't know for sure whether what we see sometimes is creatinine creep that you see with very long-term TDF, whether that's going to improve with TAF, but I think the data are encouraging that may be the case. Certainly the effect on the proximal tubule is much less with TAF. And this is now, so now there's 3 forms of TAF. There's and the single tablet with L-vitigrapher Kobe and FTC, and a single tablet with rilpivirine and FTC. And now, just approved in the last month, is what I call TAFADA. It's TAF plus FTC, which is similar to Truvada, and that's called Descovy. Just so you know, I'll say the trade names one time. And again, if you do the same sort of study, taking people that are on TDF FTC and switch them to TAF FTC, suppression is maintained. And the same sort of thing you see an improvement in bone density, and you see improvement in renal tubular function. And this is a study of again, this combination with TAF, L-vitigrapher Kobe, FTC, showing that you can actually give it to people that have creatinine clearances down to 30. And in fact, there are a few people that were actually less than 30, who were above 30 at screening, but were a little bit less than 30 at baseline. And you can see that over a 2-year period, there didn't appear to be any significant decline in renal function. So TAF can be used in people whose creatinine clearance is down as low as 30. This is doravirine. Doravirine's not yet approved. It's in a large phase 3 study. It has some advantages over efavirenz. The company that's worked on this drug did a very careful assessment of this drug in preclinical animal studies and was able to actually detect some CNS abnormalities in animals with efavirenz. So they developed a drug where they didn't detect those abnormalities. This drug is going to be 100 milligrams. It likely will be in a single tablet, though probably with TDF, not with TAF. And you can see in this particular study, very, very similar efavirenz and doravirine. There was some suggestion at higher viral loads, doravirine wasn't as good. The numbers are small. This was not statistically significantly different, but obviously we need to wait on the phase 3 trial. But we may have another first-line therapy that could be used instead of efavirenz. And unlike rilpivirine, this drug certainly can be taken with food, but doesn't have the PPI interaction, and has substantially less central nervous system side effects, and surprisingly, actually less less diarrhea than efavirenz, which isn't something I associate with efavirenz. But if you look at abnormal dreams, headache, insomnia is the other way around, because I think efavirenz makes people sleepy, and sleep disorders are all a little bit less with doravirine. So what about 2-drug therapy? In South America, lopinavir ritonavir plus 3TC, lopinavir ritonavir plus 3TC was compared with lopinavir ritonavir plus 3TC or FTC plus a third nucleoside. About half was zidovudine, and then TDF was also one of the partner third nucleosides. And you can see actually in this study done by Pedro Kahn, actually the 2 drugs was slightly better. And the argument, I think, has to be that the tolerability was slightly better. But again, this is a boosted PI. This is lopinavir ritonavir. We don't use that much anymore. So Dr. Kahn, Pedro Kahn, actually studied dolutegravir plus 3-TC. So just an integrase inhibitor plus 3-TC. 2 drugs, 2 simple drugs, 2 small pills, and if you have patients that don't like big pills, which we have. And this is, they studied 20 patients. So here's 1 through 20. A few of them had high viral loads, not all, but most had low viral loads, and that was by design. But what you can see is by week 12, every single person is suppressed. Yellow is suppressed. By week 24, everyone is suppressed. So we'll see if this actual 2-drug therapy is sufficient for people. And there's a study going on in the ACDG where we're doing a very similar study, except it's larger. It's about 150 people, and we're allowing viral loads up to 500,000. And then literally just a few days ago, there was a very small study of 9 people from Italy where they were actually treated with dolutegravir monotherapy, which I am not recommending at all. But they did do it, and they were all suppressed. Varying amounts of follow-up, but some beyond 24 weeks. So these are some of the places that we're going. Obviously, we have excellent therapy now. The currently recommended DHS guidelines therapy, which David is on the DHHS guidelines, are absolutely fantastic therapies. If we need to maintain therapy for life, what else can we do? Well, there's hard-to-reach populations that have substance use, depression. We have children, we have adolescents. There are people that have life chaos, travel, dislocation for work or safety. Fortunately, here we don't have a lot of dislocation for safety, but that happens throughout the world. But it can happen here, obviously. The Katrina in New Orleans would be a good example of many, many people dislocated for safety. Surgery, drug interactions, pill fatigue. Well, what about long-acting therapy? Can't we do something so that we don't need to give therapy every day? And the answer to that is yes, but it's incremental, right? The first steps are not going to be perfect. So cabotegravir, which is a cousin to dolutegravir, has a long-acting formulation that is created by making these nano suspensions. Rilpivirine, which you're very familiar with, rilpivirine, also has a long-acting formulation, nano suspension. And so these can be provided by injection. Okay, so this is not perfect yet. These are injections, and they're IM injections, so they're not trivial injections, but they are injections. And if you get 1 injection of cabotegravir, right, a single injection, depending on how much is injected, this is how long you can detect active drug in the blood. This is not hours or days. This is weeks. So if you get an injection, there are actually detectable levels, depending on the dose, up to a year. So that there's a potential for this therapy to be relatively infrequent. Obviously, you don't want levels that are too low. You want levels that are above some threshold that we think will suppress the virus. But this is a step. And you might say, well, that's only 2 drugs, Dr. Eron. Don't we give people 3 drugs? Well, we mostly do. I've showed you some examples of 2 drugs. This is not long-acting therapy. This is pills. These are patients given cabotegravir pill and rilpivirine pill. They first had to be suppressed on 3-drug therapy. So they got suppressed on 3-drug therapy, but then they were switched to these 2 simple pills, and you can see that they maintain suppression out to 2 years. So these 2 pills maintain suppression. So the next step, of course, is, well, let's get people suppressed and then give them injections and see how it goes. So we participated. Susan there in the 5th row has given a lot of these injections to people. So if you have any questions about them, don't ask me, ask Susan. But here's the study designs. This is called Latte 2. It's IM, so it has to be given IM. They get suppressed on cabotegravir and abacavir 3-TC, so a very potent integrase 2 nuke regimen. And then at week 20, they're randomized. They're randomized to get an injection every 4 weeks, injections, plural, every 4 weeks, injections every 8 weeks, or to continue on the oral therapy. And while this is not a phase 3 study, it's not a small study. Notice there are over 100 people in each of the injectable arms. So this is reasonable information. And this totally surprised me, to be honest. This is the proportion suppressed 8 months after starting injections. And if you were getting injections every 8 weeks, 95% were suppressed. So that's about 105 out of 115 or so, a little higher than that. 94 on every 4 weeks, and actually the oral therapy numerically didn't do quite as well, though obviously these aren't statistically different numbers. And nobody in any of the arms developed resistance. We did have like this tiny freak out at our site because we had a patient who was suppressed on the injections, and his viral load came back, I forget what, like 80 or something, or 75 or some number like that. And normally when you do that, you call people up and you say, "Are you taking all your pills?" And they say, "Oh, no, I forgot to take them last Thursday." But this guy got an injection. You can't call him up and say, you injected him, you saw it. Fortunately, his next viral load was below detectable, and it might have been one of these blips that happened. But it was really an odd experience for me because there really wasn't anything to do but worry. So, and this just shows that the proportion suppressed is very high. Some people were not suppressed because they just didn't have data in the appropriate window. One person discontinued for lack of efficacy, and their viral load was above 50, but that person did not develop resistance, and another person discontinued for another reason while the viral load was above 50, but also that person didn't have resistance. For the most part, the people who are in this study, and remember these are people that said, "Oh, I'd like to try an injectable therapy," the people in this study have elected to continue in this study and are pretty satisfied with being on the study. But they are intramuscular injections in the gluteus medius, so they're not trivial injections. So this is a really neat drug. I'm not going to try to say the name. You can call it EFDA. That's what I call it, or you can call it MK8591. This is actually a nucleoside reverse transcriptase translocation inhibitor. You don't have to remember that, but it works like our nukes, but it also freezes the reverse transcriptase enzyme so it can't move along, it's stuck, and it works really well. These are data from in monkey cells, but they're similar data in human cells. This is kind of tenofovir activity, which is actually very, very good. And this is EFDA. It's about 1,000 times more potent than tenofovir. And it has an extremely long half-life once it gets inside a cell, either a peripheral blood mononuclear cell or a macrophage. And this is the treatment response. Only 6 people. The treatment response given, I think it's 10 milligrams. Now, so you say, so what? Well, this is one dose of 10 milligrams, not 10 milligrams every day. There's a single dose of 10 milligrams lasting for, I don't know why they did this 250 hours. It's obviously, they could have done days, but obviously it's 10 days, 250 hours, right? 24 times 10, 250 or so. So this is potentially where we're going, right? Again, my slide got messed up, but this is Implanon, right? It's a implantable birth control. It's a little tiny stick that gets implanted and lasts for a prolonged period of time. Well, MK8591 or EFDA is formulatable into this little piece of plastic or whatever it is. And it actually has been tested sub-Q in rats, and it actually at least elutes drug. So there is potential for really long-acting therapy. And this is what Dr. Cohn was talking about when he talked about a recombinant vector. It's essentially a virus particle that can make proteins. And if your treatment is a protein, now obviously non-nukes, nukes, protease inhibitors are not proteins, but vaccines are proteins. What else did we give people for a while that's a protein? And they call it little nodules and they hurt. T20, anybody remember that? No, everybody's too young to remember T20, Fusion. That's a protein. You can get one of these things to make something like that, and then it could persistently make it for months or even years. So that's the potential future. So the other reason why we need new drugs, and I'm sensitive to the time here, is unfortunately a resistant virus will always be with us. It's more of a problem, I think, in the developing world. It's more common now in the developing world. What we have in the U.S. is because we can monitor viral load. This is a study done in the U.K., 9,000 patients, all treated with a first-line therapy. In this case, the therapy contained TDF, and they sent me this data because that's the data they had. But this is the proportion over 5 years that have virologic failure, 9%. This is the proportion with virologic failure that has a resistance mutation, less than 5%. If we monitor people on therapy, the likelihood that they'll develop multi-drug resistance is extremely low. But, at least in my clinic, and I imagine in Case's clinic and other people, we do have this situation. So in the US and in Europe, the viremic patients, so patients that have a detectable viral load with multi-drug resistant virus, they exist, they're out there, they're maybe having trouble with adherence, but they're a small percentage, right? On the other hand, at least in my clinic, I have a lot of patients that have multi-drug resistant virus, but they're suppressed. And some of them are on 3 therapies, 4 therapies. Some of them I know are resistant to almost everything except for 1 or 2 drugs that they're on. And they come to clinic and I'm like, please be suppressed, because I don't know what I'm going to do if they're not suppressed. If they rebound on, darunavir, ritonavir, etravirine, and dolutegravir, I don't know what I'm going to give them next. So this does exist. This is a problem. And the good news is, I'm going to skip this, there are some things being developed, right? We know dolutegravir and this new drug, this other integrase being developed, works against some integrase-resistant variants. TAF, the TAF drug I mentioned, might have some activity against nucleoside-resistant variants. That drug EFDA that I was kind of excited about because it's very long-acting, turns out it's very active against multiple nuke-resistant variants. Doravirine has some activity, but what we really need are drugs that work by new mechanisms. Because we know when we get a new mechanism, like when we got integrase inhibitors, so many people that we could never suppress got suppressed. So there's a maturation inhibitor that's being developed and an attachment inhibitor that's being developed. And as Dr. Cohen mentioned, these broadly neutralizing antibodies, if we can actually get them to work, could be used in some of our patients that have resistant virus. And I'm just going to just quickly show, this is a maturation inhibitor. It works by, in order for the virus to form this nice, neat core that's infectious, the GAG protein has to be chopped into little pieces, and that's done by the protease enzyme. And obviously, protease inhibitors work here. They block this nice cleavage thing, and the virus that's released is not infectious. That's how protease inhibitors work. Well, maturation inhibitors work in a similar way, except they don't bind to the protease enzyme. They bind to one of these cleavage sites. And again, the virus doesn't mature and it's not infectious. So they could be synergistic perhaps with protease inhibitors. They work against protease inhibitor resistant virus. And obviously they would work against viruses resistant to nukes or non-nukes or integrase. And this drug works. This is just a monotherapy, so short course monotherapy, showing you that if you give this drug, this maturation inhibitor, as a single pill once a day, you can get about a 30 to 40-fold decline in viral load. So this is a new drug that works by a new mechanism that is now actually in development by very close colleagues of ours at ViiV Healthcare. This is just giving it for a longer period of time in combination. So this is combination, two-drug combination, the maturation inhibitor with atazanavir, either atazanavir unboosted or atazanavir with ritonavir. Small numbers, very small numbers, but it clearly works in that setting. Oh dear, that looks blank. I may be done. Those were the attachment inhibitor slides. There is an attachment inhibitor that works by blocking the entry of the virus, binding to the envelope protein, and that also has been shown to work in short-term studies. It has some problems. It has to be dosed twice a day, so that's an issue. It also might not be active against all viruses. If you think about how variable the envelope of HIV is, it's not too surprising that if you have something that attaches to the envelope, there might be some envelopes that it won't bind to. But it's also, this drug, the attachment inhibitor, is in phase 3 study, and that phase 3 study is almost completely enrolled. We enrolled our first patient 2 weeks ago. Donna enrolled this patient. And remarkably, the woman had a very brisk treatment response during a 10-day functional monotherapy period. So we're hopeful that this drug will help us in those small number of patients that need a new drug. And then finally, I'm just going to talk for a second about the broadly neutralizing antibodies. Dr. Cohen mentioned that they're broadly neutralizing. Well, they're about as broadly neutralizing as sequinavir monotherapy. Okay, so you can get excited if you want to, but they suppress about 80 to 90% of the viruses worldwide. That's very good for an antibody. But if you want to use it as a therapy, you probably need to use at least 2. Here's 2. 3 is this gray, right? And then 4 of these monoclonals. This is all in the lab, not in any people in the lab. 4, you get this curve. And the reason, this is the milligrams, right? If you got to give the antibody such that you have to get a microgram per ml in the blood, there's no way you're going to fit any of that into one of those little virus packages or a shot. You've got to get concentrations that are very, very potent. So if these are going to be used as therapy, they're going to have to be used like we use our drugs in combination. So anybody who's in the audience has been holding their breath since Dr. Cohen's talk for monoclonal antibodies, you can breathe, because it's going to be a while. But for therapy, for prevention, it might well be different. I'm going to skip that. I'll skip that. So anyway, when I was asked to give a talk at the retroviruses CROI conference and about antiviral therapy, and I thought, geez, what am I going to say? Our antiviral therapy is so good. If I could just get up there and say, just take the drugs that we have. But that would have been a short talk and maybe disappointing. But Dr. Cohen, is smart. He said, why don't you think about what's happened in HIV therapy over time, and you'll realize that things always seem to change, right? So the HIV virus was discovered by these 3 people in 1983. In 1987, remarkably, 4 years later, we had zidovudine monotherapy. You might not say, oh, so what? So zidovudine monotherapy saved people's lives for a short period of time, but it clearly did. Then we had triple drug therapy. There's some people look old enough in the audience to remember saying you have to take all these pills. That was in 1996. So in a 10-year span, we came up with what was kind of prolonged life-saving therapy. Then 10 years after that, we had the single tablet regimen. And now we have a lot of them. And I'm going to argue that now, 6 or 7 years later, we're in a new era. We're in an integrase inhibitor era. Therapy's moving towards integrase inhibitors as first line. And maybe this is a little optimistic, 2017, maybe 2018 or 19, we'll have long-acting injectables, and it's possible in another 10 years we might have implantable therapy that could last 6 months or a year. So I think, again, our therapy's changing, and we continue to improve it. But again, the single most important thing is to get people in care and get them on therapy, and those people who are in care, get them to stay on therapy. And thank you very much. So we do have time for questions if people have questions. It's great if you do. Can ask anything, patient questions. Oh. Go ahead, you're going to have to shout.
Can you talk about what stably virally suppressed means?
Yeah, so stably virally suppressed, that's a great question. What that means to me is that the patient is on therapy and the vast majority of their virus levels are below the limit of detection. We do know that people will have these blips, they will have viral loads of 60 or 80. And most of those people, when we recheck them, they'll be suppressed again. But that's what stably suppressed means. And some of those numbers, like, for example, I think the WHO thinks of less than 1,000 as stably virologically suppressed. You'll see some studies where it's less than 400 copies per ml as stably suppressed. The lower, the better. I don't think, who knows? We may. But I don't think in the near future we're going to have assays that are much more sensitive than the 20 to 50, depending on what you're using. But that's what I mean. Consistently less than the limit of detection. That's stably virologically suppressed. Occasionally there are patients, I have a couple that had huge viral loads at baseline who are stably virologically suppressed with a detectable viral load of 100 or 100, but those are really rare. And I've actually sent resistance tests on those patients and even this archived resistance test, and they're not evolving. So I think they are, in fact, stably suppressed. But for the most part, it means less than the limit of detection. Other questions? She break the ice? Go ahead, please.
On your, I don't know what you call your tax page, but over years of treating with different meds, and now we're in the integrase inhibitor era, there was also a resurgence of NRTI only.
Yeah, that's a good question. I think the problem with that is that it's an observational database, and it has to be completely cleaned. Hopefully there are no patients in our clinic that are being started on NRTI only. One thing that happens in the database is that if someone started on a research protocol where the patient has to supply their own nucleosides, and then they get a third drug that's provided by research, that might be picked up as nucleoside only initially. So I think it's a database issue as opposed to anybody using nucleosides. I think it's not happening. All right.